पुन्हा एक फोन करून मला चार्जर लावायचा.
Good afternoon, respected dignitaries. Today, we all are gathered here for the webinar on sexual health presented by AMOG's Medicine Committee. Sexual Health for All. This is the episode 10 of Core Connect Live webinar, organized by Corona Remedies and AMOGs. So, for this, I would like to introduce our convener, Dr. Madan Kamble, who is the chairperson of SMC and AMOGs. Dr. Madan Kamble is consultant and sexual health expert. He is aesthetic gynecologist and sir is also the chairperson of AMOG Sexual Medicine Committee as well as national coordinator of FOGSI Sexual Health and STI Committee. Sir
It's
has
okay,
been
Bhavna. It's
past
okay.
secretary and president of Akluj OBGY Society. He has multiple awards such as Wonder Amoxian Award and Legends of Gynecology Award. Some of the
It's okay.
publications are AMOG's focus
Thank you.
on sexual health. Sir, I would like to hand over the session to you now to introduce Dr. Neeraj Jadhav.
Yes, thank you. Bhavna from Corona. It's my pleasure, privilege to welcome you all for this wonderful session today, especially organized, which is the Sexual Health for All episode 10, organized by AMOG Sexual Medicine Committee. For this wonderful session, today we have got the main invited Chief Faculty, Dr. Neeraj Jadhav, sir, who is the past chairperson of FOGSI Sexual Health Committee. It's my pleasure to introduce sir. He is the past chairperson of Sexual Medicine Committee of FOGSI, which is the award-winning committee for his tenure. He was past vice president of Rajkot Menopause Society also, secretary and president of Rajkot OBGY Society in past, also organizing secretary of SOGOG 2014. He has organized so many conferences and he is a very great academician and very interested person in sexual health. I welcome you, sir, for this session.
Thank you, Madhu.
Yeah. Bhavna, please share the CV of Alpesh, sir, our chief guest. Yeah. CV of Dr. Alpesh Gandhi, sir. Welcome, Pardesh, sir.
Dr. Madan, I do not need introduction, I think.
Still, sir. Dr. Alpesh Gandhi, sir, is the past president of FOGSI. He is a wonderful academician and great Foxian and very good human being. He is always down to earth, always accepts our invitation, and always, when I meet sir in the conferences, he is very polite and the most respected person in the FOGSI. I welcome Alpesh Gandhi, sir, and I request you, sir, for your blessings. Over to you, sir.
So thank you, Dr. Madan, for the kind words. And I think we do not need any appreciation in friends. I can see you also doing a good work in this AMOGs and in committee. Very good evening to all the distinguished faculties and my dear friend Kiran Kurkoti and Bipin Pandit and Dr. Rajendra C. Pardesi, Dr. Sampat Kumari, and Dr. Bharti Abhyankar. AMOGs, I'm so happy to see that I'm frequently invited as a guest in AMOGs so many webinars. I can see Amox is doing a lot of activities and very vibrant under the able leadership of Dr. Kiran and Dr. Vipin. So I would specifically like to congratulate both of them as and my special regards and hello to Dr. Rajendra Pardesi, Dr. Sampath Kumari, and Dr. Bharti Abhyankar, and today's coordinators, Dr. Madan and Dr. Vaibhavi Thakur. A very good evening to all of you. At the same time, I would also like to congratulate Dr. Neeraj Jadhav for his wonderful academic work. I've seen him working during my presidency, and he during this period he won this base committee award also. So I am so happy that to see that committee which is not so much important at that time, or we can say not much discussed, but he took this committee at a different level, and now a lot of Foxy members have generated interest in this committee to work in this committee, and this is a very good sign for Foxy and a very good contribution towards Foxy by Dr. Neeraj Jadhav. So I would like to appreciate Neeraj for his this work. Sexuality is, we can say, an important aspect of health which can impact the overall well-being of women, men and women both, and we all need to learn the basics of it. It should be included in the curriculum. Many times I have mentioned in the undergraduate and postgraduate, and it's our we can say our duty, I would say, to learn it thoroughly, improving the training of undergraduate medical and nursing students in sexuality related issues, increasing trained individuals in sexual medicine by starting new courses, providing sex education to general population using media, and merging sex health care with primary care are likely to play a significant role in addressing the increasing sexual health morbidity. It is usually not much discussed topic, but it's a incidence is very high, and we can say the different studies have suggested the incidence is in female it is from 14 to 20% in as per the different studies. 14 to 20% women are having sexual disorder, means out of 6 or 7 female, 1 female is suffering from sexual disorder. So incidence is very high, and therefore it is very important for all of us to attend such webinars regularly and to learn and to update ourselves from the experts. Like today's we have all these expert eminent faculties to discuss all these aspects, and we had a wonderful, I think the topic of panel is female sexual disorder. So I think it will cover a lot of topics, many topics. My best wishes to Dr. Neeraj Jadhav for his endeavor in Foxy, and my best wishes for success of this webinar. Thank you very much for inviting me, giving this honor and giving this opportunity to meet all of you on this platform. Thank you very much.
Thank you, sir, for your kind words and blessings and taking time for us and being with us today. Thank you, sir. I would over to you, Neeraj, sir, to welcome the guest of honors.
So thank you, Alpesh Bhai, for your giving time to this webinar and giving your blessings to all of us. So
I just joined. I was little late. Sorry for that. I just joined from the webinar of Dr. Rakhi.
You are very much on time, sir. Not an issue.
On time, sir. Yeah. Thank you, sir.
Bhavna, next slide, please. Dr. Kiran. Yeah. So
Kiran sir is not there actually.
Yeah. So
He will join later.
I think he is busy, but whenever he joined, we will take his blessing. You all know Dr. Kiran Kurkoti. I don't need to introduce him. Is very known figure in your AMOX as well as nationwide. He is currently president of AMOX. So whenever he joins, we will take his blessings. Next one, Bhavna. So it's my privilege to invite our next guest of honor, Dr. Bharti Abhyankar. She is worked as a chairperson of the Preventive Oncology Committee of AMOX, twice as a general coordinator for AMOX, and organized so many conferences.
Thank you, sir.
Currently
Thank
Vice
you very
President of
much.
AMOX. So over to you, Dr. Bharti Madam, for your kind
Yeah.
words.
Yes, sir. Thank you. Thank you so much for inviting me and giving me the honor of attending and be a guest of honor for this wonderful seminar. I always appreciate the efforts of Dr. Madan Kamble because he is taking a topic which is very much needed, but which is very much neglected also. I come across many doctors who are literally unaware about the sexual health. And I really appreciate Dr. Madan's effort to do all these webinars. I think he's doing it for last 3 years also. So once again, I congratulate him and my best wishes to you and the entire webinar. Thank you, sir.
Thank you, Bharti Madam.
Thank you, ma'am. Thank you.
It's a privilege to introduce our next guest of honor, another giant figure from AMOX as well as in FOXI, Dr. Rajendra Singh Pardesi, sir. You all know him as the past president of AMOX and vice president of FOXI also. He was there. And welcome, Pardesi, sir. Over to you for your kind words.
Sir, you are muted.
No,
You are
no,
muted.
sir is not muted, but I think. Sir, we can't hear you. Still audio is not there. Pardesi, sir. No, something problem with your audio, sir. You can log out and log in again. We can't hear you, sir. Pardesi, sir.
सर आवाज येत नाहीये. लॉग आउट करून परत लॉग इन करा.
Madan?
तोपर्यंत हे करूया का?
Sir, you can log
Disconnect.
out, log in. Pardesi, sir.
I think till sir joins, we can take blessings of Sampath ma'am.
Yeah. So it's privilege to invite our next guest of honor, Sampath Kumari Madam. I was fortunate enough to work under her when she was a chairperson of the adolescent committee of FOXI. I was her Western coordinator. She is also past president of FOXI, vice president of FOXI in 2022. Thank you, Sampath Kumari Madam, for joining. Over to you for your blessings.
Thank you, Neeraj. It was really, as all of us was telling, the topic sexual health, which is important and neglected by many people. And I am happy to be the guest of honor, where Dr. Alpesh Gandhi was the chief guest, and he was the president who did a lot of webinars during the Corona period. And as everyone told, he is a good human being. And the co-guest of honors, Dr. Rajendra Singh Pardesi, and Dr. Kiran and Dr. Bharati. Rajendra Singh Pardesi sir is one of my best friend and who is also the well-wisher. And you have the important coordinator and convener, Dr. Madan and Dr. Vaidegi. Madan, I think he is also doing a wonderful work. In future, he will take over what Neeraj has done, I think. Anyway, all the best to
Thank
Dr.
you, ma'am.
Neeraj for everything. And all the best to the webinar. Thank you, Dr. Neeraj and Dr. Madan.
Thank you, madam.
Thank you,
Pardesi,
ma'am.
sir. Can you just try out? No, I think there is a problem with audio, sir. Audio.
ऑडियो येत नाहीये सर.
सर ने दूसरे उसमें से लॉगिन किया हुआ है, आई थिंक. इफ सर कैन जॉइन फ्रॉम दैट ऑल डिवाइस.
सर मोबाईलवरून लॉग इन करा.
हाँ सर का
चालेल.
है, दूसरा दिख रहा है. There are two devices, sir. as
Sir,
well.
the problem is he is, I guess, not joining the audio while joining the Zoom session.
हा.
So meanwhile, we can do light labeling till sir's problem solved.
Hello.
Yes, sir. Yes, sir. We can hear you now. Please, please. Yes, sir.
Hello. Good evening, everybody.
Good evening, sir.
गुड इव्हनिंग.
Respected Chief Guest, Dr. Alpesh Gandhi, sir. He told he has been invited many times in AMOGS because we know him, Alpesh Gandhi. Alpesh nahi, Alpesh Gandhi in Maharashtra. Guest of honor, Dr. Sampat Kumari.
Thank you.
And our beloved President, Dr. Kiran Kurtakoti, Dr. Bharti Abhyankar ma'am, Dr. Bipin Pandit, and our friend, Dr. Neeraj Jadhav. First, I wish to congratulate Dr. Madan Kamble and his team with Dr. Neeraj Jadhav, Dr. Vaidehi Thakur for organizing his 10th episode of series of sexual health for all. And with the expert faculty like Dr. Neeraj Jadhav, with his panelists, Dr. Purnima Ende, Dr. Kahalekar, Dr. Gulwade, Dr. Gadekar, Dr. Belokar, Dr. Rewardkar, Dr. Khandare, and Dr. Mahamuni, Dr. Pagania, and Dr. Khalatkar. I think this is going to be a great event on female sexual dysfunction. I wish every success to Dr. Madan Kamble and Dr. Neeraj Jadhav also for their future endeavor in FOXI and for this event also. Thank you. Thank you so much for inviting me. Jai Sri Ram. Thank you.
Thank you, Professor sir.
Mhm.
Over to you, Madan, for your.
Yeah. Thank you, Pradesh sir, for joining and blessing us. Bhavna, please open the CV of Dr. Vaidehi. Yes, Dr. Vaidehi Thakur. She is the coordinator of FOXI committee also AMOG Sexual Medicine Committee. She is a good friend of mine. She is a surgeon commander in Navy, Indian Navy. She has received so many awards and she is fellow in gynec oncology, also reproductive health and diploma in cosmetic gynecology. She is very active person in sexual health committee. I welcome Dr. Vaidehi and over to you for the scientific session.
Am I audible?
Yes, yes.
Yeah.
With the insightful groundwork laid, we now turn our attention to a pivotal scientific topic, which is of immense importance, yet one that has historically been less discussed: female sexual dysfunction. Guiding us through this vital conversation will be our esteemed chief faculty and excellent moderator, Dr. Neeraj
Yeah.
Jadhav, sir. We are delighted to
Vaidehi,
announce.
Vaidehi, just 1 minute. Our lamp lighting is missing. Bhavna, please.
Yeah, before we start.
Bhavna, please open the video of lamp lighting. I welcome all the guests for lamp lighting of this e-lamp lighting. Please play the video. I request all of you to join. Thank you once again, all. Thank you for joining. Please proceed.
So we are delighted to announce that we have a highly qualified panel of experts joining us to explore this complex subject in depth. Can you display the slide for the panelist? Introduction to the panelist. Dr. Purnima Yande, ma'am, she is former secretary of Beat OBGYN Society, and she is a cosmetic and regenerative. She is expert in cosmetic and regenerative gynecology. Next slide, please. Next slide. Dr. Mekshri Kahayekar, madam. She is from Nagpur, and she was the NOGS. She was the past president of NOGS, and she has done advanced training in infertility from Chennai Fertility Center, and she is basically a laparoscopic surgeon. Next slide, please. I couldn't see the. Because of this, yeah.
Yeah, there is some.
Kalpana, madam, has she joined? Kalpana,
No.
ma'am, has joined.
No, she is not there. But
No.
you can introduce her. And
Introduce.
She is the organizing. She's from Chandrapur, and she was the organizing secretary of amongst 25 Chandrapur, and she is the advisory member of district PCP entity committee. And next slide, please. Next slide. Dr. Kavita Kadekar, madam. She is from Nasik, and she is a certified endoscopic surgeon and sonologist and infertility specialist from. She has done these courses from Vadia Hospital, and she's from. I couldn't see the slide properly.
Yes, it's very.
Can you
Enlarge
she's,
it.
She is clinical secretary of Nashik OBGYN currently.
yeah, she's clinical secretary from Nashik OBGYN Society.
Yeah. Next.
Next slide, please. Hello. Dr. Poonam Belokar, madam. Has she? I don't think she has also joined.
No, she is also not there. But
she is consultant OBGY from Amravati, and she is secretary of OBGY Society from Amravati. She was Pragati Kharkar, madam. She is from Nagpur, and very dear friend of not dear friend, I should say, but a very adorable person. I used to adore her very much. She is from Nagpur, and she is hold lot of posts. She was president Menopause Society from Nagpur and vice president Nagpur OBGY Society. And she has got a lot of achievements to her credit, and she has presented papers at many national and international conferences. Dr. Ashi Pargania, she is a consultant urogynecologist from Nagpur again, and she has done fellowship in urogynecology and pelvic floor reconstructive surgery and advanced infertility training from Sir Gangaram Hospital in New Delhi. Dr. Aishwarya Revadkar, she has again got a huge experience, and she has done fellowship in IVF, and she has also to her credit 3 books, Bijapur Diary, Virichi Mulgi, etc. And she has worked as a gynecologist at Cochin Natural Birth Center. Surya Kumar Khandare, he is again from Satara, and he is director of Arya Vidhi Hospital Satara and director of Puja Nursing Home Koregaon. Snehanjali Sutar, she is again from Satara. She is director of Sai Nursing Home Satara, and she has done fellowship in laparoscopic surgery and fellowship in cosmetic gynecology. So I think, so over to you, Neeraj sir, and we request to start with the panel.
Thank you, Vijay. So Welcome all the panelists, welcome all the delegates who have joined for today's webinar. Let's start our scientific session. So we are here today to discuss about the unspoken problem that is hardly discussed by patient as well as by clinician or as a gynecologist also. We hardly discuss this problem with our patient. So let's explore the female sexual dysfunction. At the outset, I would like to seek your blessing and support as I am contesting for Vice President Foxy West Zone. Election will be held from August 1st to 10th. So please vote and support me. So I request Dr. Madan to join me as a co-moderator. All the panelists have been introduced by Dr. Vaidehi. So welcome all the eminent panelists for today's panel. So it's about sexuality and the we gynecologists. What are the problems? Because sometimes there is a lack of training. This sexual medicine was not taught in our medical days. So we lack the skill of the sexual medicine practice. Our OPD is full, our labor room is full. So there is a lack of time, and sexual medicine is a topic or issue that require long session and long counseling hours. So it's also one of the reason why we are not touching the topic of the sexual health. And sometimes we as a doctor fear that by asking the intimate question to our patient, patient will be embarrassing. So that is also one of the reason. Sometimes we feel there are not enough option to manage such type of dysfunction. Sometimes we also believe that the sexual dysfunction decrease with the age and it should be accepted as it is, but we all know it should not be like that. And sometimes our personal belief also interfere about the tackling the issue of the sexual dysfunction. When I was chairperson of Sexual Medicine Committee, Foxy, we did one survey where we asked a question to our fellow gynecologists. One of the question was about the training in sexual medicine. So you can see the result, around 9% only have some course related to sexual medicine. Around 32% have attended some CNA related to sexual medicine. But you can see the figure. Around 62% of our gynec friends have no exposure to any type of course or CME. So there is a vast gap when it comes to the sexual health, managing sexual health problem. So I'm sure in coming days, Foxy is doing sexual medicine committee is doing it work in MOX. Madan is doing great job, banks doing so many CMEs and webinar. So in future, this figure will go down. I'm hopeful about that. So Madan, you can take up the first question. And all the panelists can take up any question, and after that, all other panelists can give their inputs about the answer. Madan?
Okay, sir. Thank you. Good evening, all. Actually, we have purposefully selected this very important topic, and everyone should be aware of and should be having some knowledge about this sexual health, disorders, and the basic management of this. We all know the definition of health and sexual health too. I would like to hear from Dr. Aishwarya, what is sexual health in your perspective? Dr. Aishwarya?
Yeah. So, should I go through this definition?
Yes, please.
Yeah.
Okay. So, according to current definition, like we define health also, overall health also by WHO. So, for sexual health, it is a state of physical, emotional, mental, and social well-being in relation to sexuality. And obviously, it is not merely the absence of disease or dysfunction or infirmity. And the sexual health requires a positive and respectful approach towards sexuality and sexual relationships, as well as there should be the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. So it is our WHO definition, 2006. So, yeah.
Perfect. So actually, sexual health is, as commonly believed, it is not only about the sexual intercourse. It has so many
Yeah.
aspects related to it, and it covers so many issues also, like
True.
sexual rights and everything, and
Yes.
should be free of the violence. So it's
All
Yeah.
panelists, please make your video on so that we can see you.
So let's jump to the next question. Because to understand the sexual dysfunction is very important to know about the sexual response cycle. So can any panelist can explain what is the sexual response cycle?
May I?
Yes, yes,
Yeah.
please.
Yeah. The sexual response cycle in 1960 by M and J was described in 4 phases. Excitement, plateau, orgasm, and resolution. This was a linear model, but it is no longer now considered. The excitement, which is a desire, plateau is the arousal, orgasm is the vaginal penetration or coitus, resolution is the orgasm. Now, female sexual response cycle is a cyclical response, which is a newer concept which has been adopted in 2001 by Basinar. And it is a cyclical response. It is correlated. It is the emotional intimacy, spontaneous sex drive, sexual stimulation, biological factors, psychological factors which promote the sexual drive and the stimulation, and the subsequent cycle of orgasm and sexual satisfaction.
Yeah, perfect. So basically, female sexuality is a little bit complex thing to the male sexual response cycle. It's not linear as it was suggested by Master and Johnson. And so basically nowadays, the circular model is more accepted, and emotional intimacy is one of the important factors when it comes to the female sexual response. Perfect. Madan?
Yes. After understanding this female sexual response cycle, let us know about the basic thing. What is how we can define this female sexual dysfunction? Yes, Dr. Snehanjali.
Yes,
go.
sir. Actually, it is a just persistent and recurrent problem which is encountered in one or more of the stages of a sexual responses. Many times, it is considered problem when, unless and until that woman is distressed about it is, or it takes it negatively affect her relationship.
Yes,
so
these 2 things are very important. There should be distress and there should be the negatively affected relationship. These are very important. Yes, you are right.
Yes, sir.
So
Yes,
basically, there are 4 stages of sexual response, and problem in any of the stage will imply it is a sexual dysfunction. And important thing is women should be distressed about it. And
May
one of the things missing in this is the time duration. It should be present at least for the 6-month duration.
Months.
Yes, Dr. Prakriti, you want to add anything?
Yes. 6 months, sir.
Want to thank Dr. Madan for bringing me here and getting me exposed to so many people and such an important, interesting topic. And I belong to that 32% of that survey which Dr. Neeraj has shown. We attended few CMEs, and from that CMEs, we have come to know where we are lying. My God, there are so many things and they are not untouched. And we gynecologists are only the person where these patients come, and all of us are really, many of us are not aware of the sexuality problems. So for me, sexuality is such a physiological process, an ancient process since years and ages. It is there. It's present in animals. It's present in humans, and it's so basic of life. And still, there is a big gap. Many of the women who have not have attained their sexual well-being, their sexual health is not proper, as the definition says. She is not even aware that she is having sexual problem. That is the such a big drawback, that they are not even the thing. There are so many taboos attached to it that they are not addressing. They are not concerned about it and not worried. But actually, if she is having dysfunction for more than 6 months and she is worried about it, the black part of the story is they are not worried. Nahi, if they have no sexual pleasure, then also they are running their life years together and then they are happy. So
Yeah.
you can treat as I said, persistent and recurrent problems encountered in one or more of the stages of sexual response, which we have just discussed.
Yeah, so you are right, Dr. Praktike. Typically, sexuality is considered, as far as female part is concerned, they are considered as a passive partner. So usually they don't complain, even if they are having a problem about the desire problem or orgasm problem, they accept it as a normal phenomena and they are not bothered about it. So it's sometimes difficult. Actual prevalence may be higher, but they are not bothered about it. So actually, prevalence comes down drastically if we consider that factor about the distress. Yes,
Many,
Dr.
many a times they would present with psychosomatic symptoms rather than sexual complaints.
Yes, perfect.
As
So
doctors, we do not want to talk about sexual problems because if she starts telling us how are we to treat it?
yes,
Because as sir said, ki even doctors are unaware how
yes.
to go about it.
Yes.
So
Good
Because
evening. Good
what
evening,
happens
sir.
now, we as a gynecologist think sexual medicine is not our specialty, it is belong to some sexologist. But believe me, there are so many branches are involved in sexual medicine, like skin BD people are doing it, psychiatric people are doing some of the sexual medicine
Psychiatrist.
practice. But what happens now, our female patients are not very much comfortable going to them.
Them.
You
Yes.
know what
Yeah,
is happening? Because we are not addressing this issue which belongs to our domain. So many
yes.
other people are doing, and psychiatrist is also fine, but then there come the quacks who are taking it over, and then they are doing they are ruling it.
Yeah,
That's
even if you ask any female, go to the psychiatrist if you are having some sexual problem, they will not go because they have some, yeah. So
And
a psychiatrist will be like, I have some psychiatric problem. She'll be better off with a gynecologist.
yes,
Actually, we should be the ones to be addressing it and we should be the ones learning it because
yes.
she feels safe to talk to us, not to others.
but maybe because of the social media, there is little increased awareness. And nowadays, we are started seeing patients who directly come and address the problem. They come in a couple and they would directly say, I have problem with my orgasm. So we also have this spectrum of new patients who are aware and they are come up with the symptoms.
Yes,
because they are guided by Google.
Yeah, that maybe, but at least some sort of awareness has started.
Yeah,
perfect. So let's jump to the next
To
question.
respected
Yes,
seniors,
yes,
can
Asif.
I share one wonderment that I always have whenever I attend classes or webinars on sexual health? I always wonder, sexual health is a luxury for us because I always wonder, what about the women of low socioeconomic class?
I would
Do they
like to
experience the
clarify
same
you
kind of
on this,
sexual
Ashi.
dysfunction?
Sorry if I'm stopping you. I work in a tier 3 city, Bid, where my population is a migrant class. There are sexual problems. They might not come to you as directly as sexual problems. The person in working class also has the same problems which a celebrity or a high class socialite will be having. So that is where cosmetic gynecology comes, because the problems for a woman, it is a human body, she is a woman, they are the same problems which she will be having what a agricultural laborer, a low socio-economic strata person will be having, the same problems a high class celebrity might be having. Only difference will be in vocalizing her problems. Our women are taught, no, like as sir said, passive. You are a passive, female is a passive partner. Now, talking about orgasm is a long shot. Only if she gets cured of her dyspareunia, मेरा pain कम हो गया, that will only be good for her. That is all that she thinks.
I strongly agree with you, ma'am. Actually, what I wonder is irrespective of class, what I would say, they are not aware, they are not educated. Sex is a taboo, definitely. They are not even aware that sexual intimacy is a normal part of their relationship, particularly pertaining to the low socioeconomic classes of women, where they are. I just keep wondering about what kind of sexual dynamics do those people have.
like where the woman is always passive, or does she have any say? Does she get any kind of excitement during the act? And is she able to achieve the orgasm with the help of their partner or on their own? I just keep wondering where
This is where we'll have to start talking about it, is what I feel.
Yes.
Yeah, no,
After 24 years of practice,
actually,
we are talking about it today.
Actually, public awareness is also very much important part of it. We should be doing about the what is the sexual health, what are the different dimensions of the female sexuality, what are the problems that can occur in the female sexuality. If we can achieve target the public now, then they will come out with the openly with so many problems. So basically, we are lacking is the public awareness about the issue.
Yes. Let us move.
Yes.
Yeah.
So can any panelist tell us what is the classification of female sexual dysfunction?
May I talk?
Yes, please.
Yes.
Kumar.
Now we are doing classification as per DSM-S of 2013. As per that, it is classified as female sexual interest or arousal disorder. It as compared to the previous DSM-4, it considered hypoactive desire disorder, arousal disorder, and orgasmic disorder. Then second classification as per DSM new 2013 is genitopelvic pain or penetration disorder. As compared to previous one, it was dyspareunia and vaginismus. And other previous classification has been abolished, where it was considered with sexual aversion, sexual dysfunction related with medical disorders or with medication. And now newer classification, it is replaced by other specified sexual dysfunction, unspecified by sexual dysfunction.
Yeah. So
we
basically,
are following to 2013 classification nowadays.
Yeah. So basically, some of the dysfunction have been combined, and basically nowadays there are only three major sexual dysfunction. One is the interarousal disorder, one is the orgasmic disorder, and third one is the genitopelvic pain or penetration disorder. Yes, madam.
Yes, as we all know, whenever there is sexual dysfunction, it is going to affect the quality of life of the woman. Then we have to think about that, and let us understand how it can affect on the quality of life. Are there any effects? We will take the question. Yes, anyone? Yes, please.
Female sexual dysfunction, it can lead to low self-esteem, sense of futility, frustration, depression, and psychological problems, anxiety, worry, irritability. And it may also lead to marital disharmony, disturbed interpersonal relationships, fights. It may also lead to divorce, which would be a very sad state of affair. It can also have a negative impact on the male partner, leading to premature ejaculation, erectile dysfunction, etc.
So it affects women in so many ways. So we should be bothered about the sexual health of our women.
We are not talking about the effect on the males, sir. Female sexual dysfunction also has an effect on males.
Yes.
Yes.
To be talked about. That has to be talked about. Male sexual dysfunction is totally neglected.
So with that becomes our first disorder, that is the female sexual interest or arousal disorder. So can any panelist tell what is the criteria when you can label patient is having a interest or arousal disorder?
Can say they are based on how the patient is affected. So it can be this low desire or there is totally absent desire. It can be absent even when they are, without any visuals. Sometimes there is some, if they are not aroused or they don't have the desire, when they land in a situation which is a sexual enhancing position, they don't, in that time, they don't have that desire. And if her partner is initiating, then also she's not aroused or she's not getting the desire to get into it. She's not excited. She's not looking for it. Or whenever she get a chance where she can use that moment, if she is not indulging into these acts, so it is pointing out that she is having some arousal problems. Even she's not responding to any sensations during sexual activity, and she showed no response, is definitely, we can say she's having arousal response. So criteria was that to make any diagnosis of sexual disorders, and when 70 to 75% of time, 70 to 100% or maximally she experienced these symptoms, and when minimally for 6 months, we can label that she's having FSAD.
Yeah. So this all three is common for all the sexual dysfunction.
And very importantly, it's causing distress.
Yes.
I don't know if it's not causing distress, is it included it or not? If she is absolutely not bothered, should we include it or
No,
not?
it's not considered as a disorder if she is not bothered about it. So you rightly pointed out there are 6 criteria, 2 based on the desire and 4 based on the different aspect of the sexual life. And out of these 6 criteria, at least 3 should be present to label patient is having a interest or arousal disorder. Madan?
Yes. Then about the evaluation of this female sexual interest arousal case, how we can proceed in this case whenever the patient comes in our OPD? Deshmukh madam.
Before that, I would like to ask your what you say, what's common in your practice? Usually patient come with your desire problem, or husband tells that his wife is having a low desire. What's your
I believe the husband comes with the wife.
yes.
Wife,
Yeah.
very rarely.
Yeah.
Wife will, if comes only if it goes to the grounds of divorce, or the husband has a mistress or she's not showing interest, then the wife will come. But most of the times, the husband comes with the wife.
Yes.
As an infertility consultant, I would like to interrupt. In many of our IVF patients, we see to it that patients have dyspareunia many times, and vaginismus is a common complaint with them, and they become infertile. And in that case, we should think of that also. Endometriosis is a major complaint in these patients, and they don't try to have sex also. And the husband complained that whenever she comes to us or whenever we have intimacy, that time she will be having pain. And the patient is also always giving a history on herself that she is having severe dyspareunia, dysgeusia. These are the complaints in case of endometriosis, and 25% of our IVF patients we see are having endometriosis. And these patients land up with definitely vaginismus, dyspareunia, and this should not be neglected along with a retrorotated uterus.
Perfect.
What I feel.
So can any panelist tell us how will you evaluate when patient present with the low desire or interest problem?
I think we have something called as decreased sexual desire screener, where you ask questions and by yes and no answers on, there are number of questions asked, whether the level of sexual desire is good, or are you bothered, and when yes or no, then when she says yes and no, then you start going through those factors, whether she qualifies for the diagnosis of sexual dysfunction or no.
Yeah. And what about history part? What will you history examination? What will you cover?
I think in history we ask history to the patient about the when she started having these problems or with low desire, but evaluation of the patient's medical history is more important. At least in our setup, whether she's having prescription medicines, whether she's having thyroid disorders or neurovascular disorders. Most of the times our patients are under some psychiatric prescriptions, and then there is no arousal at all. Or so such or over-the-counter medications are used for a headache or backache. And as madam rightly pointed out, dyspareunia will be the most major complaint. She goes into a cycle. Once she is having severe pain, there is no sign of interest for sex. So she keeps pushing the husband away, and then we start labeling her with different conditions like sexual dysfunction. So dyspareunia is the main cause.
Yeah. So Dr. Purnima, according to you, how we should take sexual history? We should take it from the patient, from the husband, or from the couple together?
I think first patient and then the couple together.
Okay.
There is the FSFI index which we keep listening about. So if on those points, if we can start history taking, it helps. But clinically, FSFI is a very big questionnaire. We
Yeah.
need some shortened questionnaire, and I think Indianized questionnaire, because our patients don't talk so explicitly about all whether you are having orgasm or whether it will only be good or bad, or pain or no pain. So certain Indianized, I think Madan Kamble sir will be doing it in next Indianized versions of the FSFI index.
Yeah, but before that we need so many research, and it's very difficult to carry out research in our part. So you rightly pointed out there is a one screener is available. Question number 1 to 4 is basically to rule out whether patient is having a low desire problem or not. And question number 5 is basically to rule out any secondary causes for the low desire or interest. So that is a basically screening method. It's very easy. You can convert in your local language also, give to your staff or to the patient also. They can fill up the screener, and then you can start taking history about the what is the different part of the problem. And you rightly mentioned about the medical history, comorbid condition, and over-the-counter drugs also can cause the low desire problem. So coming to the management part, basically there are 3 parts. One is the counseling, one is the psychotherapy, and third one is the pharmacotherapy. Madan?
Yes, sir. Counseling, we all know the importance of counseling. We really need the skill for that, and counseling plays a very, very important role in management of any sexual dysfunction. I think it plays a more than 90% role, and very few cases require the pharmacotherapy. Yeah, I would like to know from yes, Dr. Aishwarya or Dr. Snehanjali, what is your opinion about the counseling? Why to counsel? How to counsel? In brief. Yes, Dr. Aishwarya, are you there?
Can I, sir?
Yeah.
Yes, Dr.
Yeah. Please,
Yeah.
please keep
Actually,
your video on. Make your video on.
Actually, sir, in OT.
Okay. Please.
Yeah. Actually, what I prefer, thorough counseling and thorough acknowledgement of a problem is very necessary, because unless and until they don't know their problem, we can't counsel them. So first, I prefer actually counseling regarding all social aspect of a social life, as well as I make them assure that whatever they are talking to me, that is, secrecy is very much maintained. It is confidential regarding whatever they are talking. And counseling of both partners, it is very necessary. Actually, in counseling, it is very helpful regarding the implicit, allow, and MABSES. So, in a implicit model, there is permission limited information, that is specific suggestions, and intensive therapy, which is very much skilled approach for the sexual health as well as general health. So we should take care regarding women with sexual concern.
Yeah.
So,
Okay. Permission means to validate the complaints of the patient, that these complaints do exist, and we have to listen for the complaints of patient. That is the permission for. And next is the limited information. Limited information means we have to educate the patient, give the information about the reproductive anatomy, physiology, and how these sexual things happen, and how the sexual relation should be. That should be in the information part. And what comes in specific suggestions, ma'am? Specific suggestions. Hello.
Snehanjali, Dr. Snehanjali.
Yeah. Specific suggestions means if in
So
any
may I-
cases.
Yes, Dr. Snehanjali.
Yes, anyone, please.
So specific suggestion should be educating patient about what is sexuality, and asking about her like what is her experience and what is the experience with her partner, and what does sexuality means to the patient, and does she enjoy it, or what are her expectations with sex and sexuality, and are any particular sexual needs have been met, or are there certain expectations that she is looking forward to in her partner or during the sexual activity. And then we also need to validate her needs, and we also need to address the issues like if sex is not possible, what are the other ways of gratification.
Okay. In the suggestions, we can have any particular investigations. If you are suspecting any medical disorder or any comorbid conditions you are suspecting, then we can suggest for example, hormonal therapy, any investigations we can suggest. And in intensive therapy, if that patient needs any referral or any, for example, psychiatric evaluation is needed, we can refer that patient to this psychologist or psychiatrist for further this management. That is the intensive therapy.
I do a blood sugars and thyroid level. Basically, it is mentioned when patient.
Yes. Any investigation. Yeah. Any investigation she may need. Yeah. And as and when needed, the referral therapy should be available, and she should be addressed well. And other the models are also available. So next slide. Yeah, allow means ask legitimate limitations and open up and work together. And another is the MEBES, that is the mind, emotions, body, energy, and spirit. The most commonly used is this Placid model all over the world. Yeah. Yes.
So coming to the psychotherapy part, can any panelist can throw light what are the options available about the psychotherapy in the female sexual interest or arousal disorder? Or it's common for every dysfunction, basically psychotherapy modalities, different psychotherapy modalities. So can any panelist take up that question about the psychotherapy? Dr. Pragati, would you like to take psychotherapy part?
Therapy is something very intense, but what I do to my patients is first I try to understand what they are complaining. I listen to both the partners. If at my level I find what is happening, maybe the patient, just counseling will itself help her to make her know what is sexual life basically. So typically these patients are given these are all technical sensitive focus and all. They give the sensation and they find out the thing. So I am not practicing all this, but what I practice I can just tell them. So after talking to them for nearly say 20-25 minutes, I can pick up the point what is bothering them. And when I find out that this lady is not comfortable, or the place is not comfortable, or she is not liking something about that fellow, or this fellow is not liking something. See, this is female sexual disorder, and normally they are brought by husband. She has no interest, or she is not brought. So then I try to heal that part. I realize to her also, and I tell this part to him also. You see, maybe she is not liking your this over drinking. Maybe she is not liking your, your this wildness. Maybe she likes some soft approach. Maybe she likes some pampering. It is always sexual. It is not always a physical intimacy and always a physical thing. Just talking, just looking at each other can solve so many problems. I just give them some very small things. I tell him to give some gifts to her. So bring some gifts. How can you open her mind and make her happy? The happy mind can be indulged in all these things. Sometimes there are problems with big families, in-laws, some familial conflicts. So I personally work on these aspects, and I even take mother-in-law also if they are aware, or some in-law person also. And then I try to keep them free. Sometimes there are so many advices from the family member to this couple. So my first lesson to this couple is, don't discuss your sexual problem in your family. come and discuss to doctor, or else they will go to their friends and they will see the approaches and they will see some quacks and some sexual persons who sick jari buti wala people. So this is the way I am dealing with these patients.
Yeah. So yeah,
Very important, actually, sir. I too agree with ma'am.
yeah. So basically, Dr. Prakti, what you are telling is about the counseling part. So basically, psychotherapy is different exercises are there and usually done by the psychologist or psychiatrist people. That there is a sensate focus therapy. They give some of the exercises to the patient. They practice at the home and come back with the response. Then there is a cognitive behavioral therapy is one of the modalities, and one is the mindfulness technique is also there about the psychotherapy. So it's basically done by the psychologist, but we should be aware that these modalities are available. If problem is not solved by the counseling, then they need the psychotherapy basically.
And we all should be aware of these modalities because we are also not aware. So
Yeah.
last talk I read very in details about the sensate focus, how they evolve, and I was also thrilled to know that okay, because what it says is many patients themselves don't know what are their their points which are to be stimulated or which should be stimulated, and they themselves are not doing. Then so these sensate focus will find it in the person. What are the what are the sensitive points in their body, and they will help him to know that, and they can tell their partners. So in this way they can move the
Perfect. Anybody want to add anything about the psychotherapy part, or you want to share any experience about the psychotherapy? Any panelist?
I had a
Yes,
couple.
madam. Yes.
I had a couple who was supposed to get married. They had come for pre-wedding counseling. The husband was telling he was not getting morning wood. Wood, what they say.
Erection.
That is the problem he had. That is erectile dysfunction. In that case, we advised psychotherapy to him, but he was already on lamotrigine in 3 months back. But in that case, what should be a suggestion to such a couple? If a couple comes to you, in that case, the female also will be involved. She will also have a problem. But the husband was giving complaint of this, that he's not getting morning wood, which every male should get. That was his complaint. And testosterone was low.
No, basically, in such cases, what happens? Does he get erection during masturbation or not? Because sometimes what happens? During a normal sexual encounter, they will not get the morning erection, but during masturbation, they will get erection. So it's basically about the everything is because of the anxiety in the mind. They are not getting erection. So in that case, psychotherapy will definitely help. By mindfulness technique is there, one of the important technique where your mind is diverted and you are not focusing on the penetrative sex and about the erection, and that will help such type of patient.
Acha. Does antipsychotics play a role in this case? That I want.
No, usually not any medicine will be helpful. If in certain cases anxiolytic can be given in.
This patient was, the male partner was already on lamotrigine. That's an antidepressant drug. So he was he was complaining that he was not getting morning wood. Was it related to that? He had already stopped lamotrigine, but still he was saying he is not getting.
Yeah.
So what should be the role?
Basically,
he was evaluated for diabetes, thyroid, all were normal. Lipid profile was done, that was normal. Only testosterone was a bit low. Everything was normal.
Because testosterone is usually difficult to, because it is so much fluctuating testosterone level. So it's sometimes not much helpful to get investigation to do the testosterone.
The question of the female was, does every male get morning wood? That I could not answer.
Yeah. Almost all males get morning erection. That is a normal or natural phenomena. You can put straight away patient husband on the PDE5 inhibitor. Once he start getting erection, he will get confidence, and then gradually you can taper the dose of the PDE5 inhibitor. Because it is very much it will boost his confidence, and that will help.
But how many days? How many days PDE5?
PDE5, depending upon the response, and once patient get husband get confidence enough, then you
100
can
that
put the dose.
Okay. That too I have done.
In this case, actually, the loss of erection was or decrease rigidity was due to the side effect of that antipsychotic drug.
It can be or
And
it cannot be.
in such cases, with the help of that psychiatrist, we can reduce or change the drug, reduce the dose or change the drug. And second thing, long-term PDE5 inhibitor can be started in such cases like tadalafil, which is more safe. That can be used on long-term basis.
Long-term basis, yes.
Yeah.
Okay. Thank
Daily
you.
doses.
Yeah.
Yeah.
Yes.
Thank you.
But the
Sir,
next
I would
question.
like to add one point.
Yes.
During psychotherapy and counseling, both partners should be assessed and counseled, and especially emphasizing that it's nothing to be ashamed of, because many times if male factor is involved, like Deshmukh ma'am said, and in such cases the man loses confidence, that may lead to the female sexual dysfunction. So both of them should be counseled that this is nothing to be ashamed of, irrespective of the gender of the partner, and they both are equally responsible for each other's sexual desires and sexual function.
Yeah, that is the most important. You have to assure that this is not uncommon thing. Many of the people get the sexual dysfunction, and you need to take treatment. It is not the same basically to take treatment for the sexual dysfunction. That you have to counsel properly.
Yes. Next slides.
Yes, pharmacotherapy. Who is telling us about what is the different options available about the pharmacotherapy for interest arousal disorder?
Yeah, I can try.
Yes, madam.
Yeah. So flibanserin is the pink pill. Like in males, there is blue pill, sildenafil. So flibanserin is a blue pill, which is a failed antidepressant. So which was found out to be increasing the sexual drive in women. Despite having, this was a prescribed medicine for depression, the mood wasn't improved, but the sexual drive was improved. So it came into the treatment aspect of female sexual dysfunction. So it is given in the form of 100 milligram oral dose at night because it causes sedation, and it should be avoided with alcohol because it is associated with severe hypotension and syncope. And the side effect is hepatic impairment. So this is one drug. The other drugs is bremalonate. This is used in premenopausal women. Vyleesi also, it's called as Vyleesi. Both these drugs are US FDA approved. The side effect, since it is a melanocortin, so the side effect is hyperpigmentation, and it is administered in subcutaneous form, injectable, 45 minutes before the sex. Also available in tablet and nasal spray. And there are other drugs like testosterone, especially advocated in postmenopausal women. It is almost given in 1/10 of the concentration testosterone which we give in men. So this is in 300 microgram per day. In perimenopausal women, if we have to address, we need to sometimes check the serum testosterone levels. And if the patient has a pregnancy and has a female fetus, so the female fetus may be prone to virilization. So it is better avoided or has to be closely monitored in perimenopausal women. So other is buspirone. This is an anxiolytic drug commonly used in psychiatric patient. So anxiety disorder patients. So this is an off-label treatment for HSDDs, which is given in the dose of 5 milligram twice a day. DHEA is a drug. Actually, it's because of its metabolism to testosterone. It is used in female sexual dysfunctions, and this is found to actually lower the morning cortisol and promote testosterone-like activity, and thus help in improving the sexual dysfunction. Sildenafil is actually the action is to increase the vascularity. So it has shown very less benefit in women. It shows more benefit in men, where it is increases the blood flow to the penis. So it has a very limited role in female sexual dysfunction.
Perfect. So with that, we complete the first dysfunction. So treatment of female sexual interest arousal disorder may engage psychosocial as well as biological strategies. Counseling with a specific model by the primary caregiver may benefit many patients. Treatment should focus on the factor that are most distressing to the patient. Psychotherapy in the form of the sunset focus, cognitive behavioral therapy, or mindfulness technique may be of immense help to the patient, and the pharmacotherapy may be offered in selective number of the patient. Madan?
Yes. Now, second important disorder is the orgasmic disorder. When sex is not enjoyable, it can become a core instead of the satisfaction to both the partners. And there are so many types. There are 4 main types of orgasmic disorder. It is primary, secondary, situational, and generalized. Orgasm means excitement, or it is the sudden discharge of an accumulated sexual excitement during the sexual response cycle, which results in the rhythmic muscular contractions in the pelvic region, which is characterized by immense sexual pleasure, and that is the orgasm. Then how we can define this female orgasmic disorder?
May I?
Yes, yes, Surya Kumar.
It is characterized by persistent or recurrent distressing compromise of orgasm related with frequency, intensity, timing, and or pleasure associated with sexual activity for a period of more than 6 months. Related with the frequency, orgasm occur with decreased frequency is known as anorgasmia. When it is related with intensity, it is called muted orgasm. When it is related with timing, it is either it might be too early or it might be too late, or it is related with the pleasure. It is known as anhedonic orgasm, pleasure dissociation orgasm disorder.
Yeah.
These are different types of female orgasm disorder.
So you rightly pointed out there are 4 parts: frequency, intensity, timing, or pleasure. Any issue related to it, then patient is having a female orgasmic disorder. So Madan has already told about the types of the orgasmic disorder. It can be either primary or secondary, or it can be either situational or general. So when patient come to you that she is having a orgasmic problem, how will you evaluate her? Can any panelist?
All these cases has to be evaluated on history of both partner. Then we have to go take in consideration physical examination of both partner. As per the findings, we have to go evaluate her laboratory investigation, and finally we have to assess her psychosomatic evaluation in end.
Yeah. What points will you cover in the history taking when there is a orgasmic problem? Yeah. What type of sexual history you will elaborate about the orgasmic problem?
We have to take the history of regarding initiation, frequency of the coitus, in type and amount of the genital stimulation, whether it was adequate for her, what about the lubrication, whether it was adequate or satisfactory for her before intercourse, length of the time of intercourse, it is too long or it does it become painful, we have to evaluate dyspareunia, ability to achieve orgasm, difficult, whether orgasm was achieving difficulty easily or distressed. Does she experience any pain? If so, when, before, during, or after intercourse, or whether she had any history of distraction?
Yeah.
We have to evaluate all these parameters in history.
Right. Madan?
Yes. Then how to go about the management of this orgasmic disorder? Yes. Anyone, Dr. Kavita or Dr. Deshmukh ma'am?
So managing a problem with the orgasmic problem, it can be sexual counseling, supportive psychotherapy, sex therapy, marital therapy. Then there can be behavioral modification therapy. There are devices available, and in certain cases, pharmacotherapy can help. So can anybody tell what is the directed masturbation?
Yes.
Yeah.
Female orgasmic dysfunction, sex therapeutic strategy, orgasm alone masturbation, orgasm with partner on clitoral stimulation, or orgasm on intercourse.
It is a behavioral technique.
Yes, Dr.
Okay,
Subramanian.
yes.
The behavioral technique conducted for 4 to 16 weeks therapy session. It involves graded exposure to genital stimulation, include role of playing orgasm response, the use of sexual fantasy like vibrators to facilitate heighten the arousal and orgasm.
Right. So there are devices available. Just you can elaborate what are the different type of devices available which can be helpful to such type of patient.
Vibrators
There
are
are
available.
Vibrators.
Yes.
There is either a vibrator or clitoral stimulation devices available.
Yes.
Are these easily available?
Yes, it is a online. You can get all everything is
These are
online.
available online, ma'am.
Yes, yes.
Vibrator we have in our hospital as I run an IVF center. We see to it vibrator is there. Many times they can't ejaculate when they want to give a semen sample.
Yes.
So we have vibrator at our place and we do
There
it.
is a very nice US-based company, Intimate Rose, which provides different kinds of pelvic stimulators and relaxants in the form of vaginal cones and vaginal stimulators. So they do provide online. We can give a link to the patient.
Yeah, and there are this clitoral devices also available, which create gentle section on the clitoris, and then patient can have a better orgasm. So basically, it is we have to teach the patient to have an orgasm alone by masturbation with the help of different devices. Then we can advise. There are techniques where patient can get orgasm with the partners when partner gives stimulation to the clitoris, and ultimately they can achieve orgasm by the intercourse. So there is basically 3 parts in managing such type of patient. So Dr. RC is cosmetic gynec. Who is cosmetic?
No, sir,
Can you-
sorry. I am a urogynec.
Yeah. Can anybody tell you about the cosmetic
Yeah.
gynec part? What
Yes,
are the
sir.
also
I can, sir.
Yes,
We
please.
talk about G-spot and O-spot here. G-spot was developed by Dr. David Matlock, and their hyaluronic acid was injected. But yeah, now in India or in O-spot, we can use PRP. PRP is given just 2 to 3 centimeter below the anterior vaginal wall on the G-spot, or O-spot on the clitoris and in the paraurethral space. These do actually work. PRP does work in causing neocollagenesis, neovascularization. PRP along with those laser devices, especially diode laser, 1470 diode laser, gives good for orgasmic dysfunctions, or this works better in GSM patients is what
Yeah,
I feel.
basically better result in dyspareunia or orgasm?
Both, sir. See, I work in a place where people don't talk much about orgasm, but the patient keeps coming back to me. This means she's getting sexually satisfied. That is why she's coming for PRP injections.
Right.
So the dyspareunia, when the dyspareunia part goes, then the orgasm part starts. If there is dyspareunia, she won't be talking about orgasm in the first place.
Right. So basically, both the G-SOT as well as the O-SOT are controversial, not yet FDA approved. But as Dr. Purnima rightly said, many of our cosmetic gynec people, friends are using them, and they are getting good result when there is an orgasmic problem. So can anybody tell, is there any role of pharmacotherapy when there is an orgasmic problem? Dr. Prakti, or you can take up what are the pharmacotherapy options available? What is the...
But I can just tell
Yes.
you, yeah. So medicines, what I read or what I think was, initially they used to say testosterone is going to be useful, and definitely it can be of help. But is it available? My question is, the drugs which were mentioned before also, all those drugs for female sexual disorder, are they available in India?
Yes, testosterone is available. Intas Pharma is using it. And many andrologist friends are using, but dose is 1/10 of the what is required for the male. So just think of the testosterone.
There is
Yes,
flubanserin available.
No, many drugs are available. Flubanserin available, testosterone है, DHA है, the
DHA is used.
Bupropion available.
But and even I have experience with Tibolon. I have given Tibolon to few of my patients, so their genitourinary symptoms were improved, and I mean it's working.
Yeah,
It is.
that we will cover in the last part. Let's keep it as related to orgasm problem. Yeah.
I was talking about
Nowadays, many companies are coming up with the nutraceutical. So many products are. Some of the companies are.
Yeah.
Yeah, sachets are there. Nitric oxide sachets, and so many antioxidant are there. Manufacturing.
I don't know whether they work really, but they definitely work like placebo. And when you tell them you have this sachet in water and you are going to be benefited, so I think it helps. That is there. But I have seen a good result with Tibolon, and sildenafil is definitely, it shows some local effects, so it can be used. DHA, okay. But I don't know how these are working. I have never prescribed for these reasons other than those multivitamins.
Correct. Yes, any very small number of the patient you will need pharmacotherapy basically when there is an orgasmic problem. But definitely in postmenopausal or perimenopausal age group, this estrogen, then androgen, and then combined estrogen testosterone therapy, they can be useful when there is an orgasmic problem. Or dyspareunia we will cover later on. Yes, Madan, you can.
Yes. Next slide, sir.
Yeah, you can cover this.
Okay. Education and assurance that the inability to orgasm during the intercourse is not an abnormal, but may be the key issues that may help the women find the sexual pleasure and satisfaction. Only women who are distressed by the problem and acknowledge that they are in charge of their own orgasm and thus responsible for their pleasure and satisfaction, they may need help. When addressing the issues with the patient, often simple permission to address the issue and education on the topic is enough to direct the patient. Only few patients need professional sexual counseling or sex therapy. Then, regarding the pain disorders, there are mainly the dyspareunia and vaginismus. Then, vaginismus is very important issue. Many of us are have been, many patients have crossed in our OPD. Then let us know about the vaginismus. Anyone can highlight about the vaginismus? Dr. Kavita, are you there? What is vaginismus?
Yeah.
Yes.
Vaginismus, this term was coined by Dr. J. Marison. This is a reflex contraction of the circumvaginal musculature of the vagina, that is the entrance of the vagina. This which generally results in non-consummation. This is either it could be a recurrent or it could be a persistent involuntary contraction of the muscle around the vagina. So this is a very commonly seen symptomatology, especially in our gynec practice, because this is something there is where pain is involved and patient now presents with complaint, despite complaints of orgasm, desire, or other symptoms.
Yeah. What is the recent definition? The recent.
So, the recent definition of vaginismus indicates persistent or recurrent difficulties of the woman to allow vaginal entry of the penis or finger or any other object despite the woman expressed wish to do so.
Yes, you are very right. Then there is the grading of vaginismus. That is the types and grading of vaginismus.
It
What are
could
the
be,
types?
superficial, that is at the vestibule, or it could be from the vestibule to the cervix, or it could be deep vaginismus. The superficial could be any pain at the vestibular area. Grade 2 is the spasm of the levator ani muscle. The patient is unable to relax those muscles. Grade 3 is patient avoids examination and she elevates the buttocks. And grade 4 is when she elevates the buttocks, she retracts and adducts her thigh. And the last, which is grade 5, it is a visceral response of the patient where there will be those will be the autonomic symptoms. Could be shaking, trembling, crying, or sweating, hyperventilating, experiencing palpitation or nausea. And most of these do have underlying organic pathology in these patients.
Yes, rightly said. Basically, it is based on the patient's history and behavior during the gynec examination. And grade 5 is the severe form. Okay, let us. What about the evaluation? How will you evaluate this case?
Okay. Yeah.
Such patients we require very good history first. Many times some beliefs, some the customs and cultures, or some religious background, or some not having proper sexuality education, some past bitter experience, some traumatic experience of the past, or some attempt to abuse the girl has been there, some domestic violence, or maybe she in her childhood she has seen something which has just blocked her sensation to get relaxed during the sexual act. And definitely sometimes it can be pathological with some painful conditions, some pain, or some spine or some bony problem. Here I just want to narrate one patient. I did a section for a patient. It was after section, when I went to clean the vagina, I found there was a huge vertical septum. So then after getting history, and I was not even able to put my sponge and clean the vagina. When I examined, I saw that there was such a broad, nearly 1.5, only sidewise, so much of very bitter small openings were there on the two sides. So then when I took the history, then I came to know that their marriage was not even consummated. And how is she pregnant? So point comes that the patient can become pregnant in spite of not getting consummated properly. And I did a section. Then we planned and we removed that septum, and then husband came up dancing to us. So you have made up a problem. So happy. So this type of things happen. So this was
Any specific history you would like to ask? Additional history? Any specific history in case of vaginismus?
First, interpersonal relationship. What are the factors that is affecting?
Always we have to ask the history of any sexual violence in the past, sexual abuse. That is very important. That might have given the impression in her mind that may cause in her childhood, in her adulthood, anytime.
Adolescent area.
Yeah, that is very important to ask.
And sometimes forced marriages.
Not like not like even forced marriage.
Yes.
Marrying the wrong person or marrying the person whom you are not interested in. Sometimes some physical not liking the other person is also a cause for that. The organs, they are also the cause for that.
So we all are reading about the recent incidents about in Meghalaya. One of
Yes.
Yeah.
Forced marriages can cause a lot of problems.
Yes. So what are the coming to the treatment part? First, we have to assure the patient, because patient is very much frightened whenever such patient come to your OPD. So we have to assure them that treatment is available. It may take times, but definitely they can be cured. And many times what happens, they will come to you, please, we don't want to get treatment for vaginismus. We only want to get pregnancy, because there is so much family pressure from the society. So, but we as a gynecologist should assure that sexual health and sexual intercourse is very much important for their quality of life. So only pregnancy is not important. Their sexual part is also very much important. And vaginismus can be managed by so many nowadays, with so many options available. We should address the medical condition of the patient or couple. Sexual education and counseling is important as in all the sexual dysfunction. First line of therapy is lubricant and anesthetic cream. Then we can give the pelvic floor exercises to some of the patient. Gold standard for managing the vaginismus is the systemic vaginal desensitization. In some of the patient, you need the anxiolytic treatment. Then there are various psychotherapy like physical therapy with or without biofeedback, hypnotherapy, cognitive behavioral therapy, sunset focus therapy is maybe play some role in some of the patient. And recently, cosmetic gynec friends are doing Botox therapy when all other options are not giving result. So can any panelist tell us about what is the systemic vaginal desensitization? It is the main part of the treatment.
May I, sir?
Yes.
Sir, this is the most commonly recommended treatment for vaginismus, and it is used with the insertion of vaginal dilators, which come in various sizes from 19 to 35 millimeters and are made up of plastic, silicone, or glass. And progressively increasing size is used according to the comfort of the patient. And it helps to stretch the vagina and allows the woman to become comfortable with the vaginal penetration. And this can be done, the patient can be helped by the therapist or along with the patient's partner.
Yeah,
And
perfect.
this definitely helps in improving the sexual distress, coital fear, and pain. And it improves the ability to have intercourse.
Yeah. So sometimes if dilator is not available, then the patient's finger
Fingers
is
can be used.
most of the time they can be used, because when a patient can start touching their genitalia, then they can start inserting one finger, then gradually they can insert 2 finger and then 3 finger, and gradually they can progress up to the sexual intercourse. So if dilator is
Sir,
available, yeah. Yes, yes.
Sir, in my practice, I encourage patients and their partner to involve in using the fingers if the dilators are not available. And the biggest selling point is like it could increase the intimacy, and it also helps the male partner to understand what is the kind of
Anatomy.
how sensitive he has to be during using that dilatation and during intercourse.
Yeah. Basically, what happened, we in India don't have a sexuality education, so many of the patients are not aware about the anatomy, physiology of the genitalia. So they are lacking, basically. So many women may be lacking about it. So it's we should counsel them. We should, if preferably, we can keep one mirror in front of the patient. Then we can show the different part of the genitalia. That will also help to relieve the anxiety and to relieve the vaginismus in some of the patient.
Sir, here I would like to mention
Yes.
one movie. I'm forgetting the name.
Yes, yes.
In counseling and sex education, patient's anatomy description is very important. There was one movie
I also
where Ayushmann Khurrana has to take OBGY, and one patient comes that they're not able to conceive. Then the female tells him that the male does not know where is vagina and he has been consummating through the anal route. So anatomy description during counseling is also extremely important.
Yeah, and there was another movie also, Rakul Preet Kaur. I don't know, I don't remember movie, but it's also about vaginismus. I am not remembering that movie. If anybody remember that movie.
Sir, earlier we used to do dilatation under anesthesia, for an imperforate hymen or something. Does it not work nowadays?
No, imperforate hymen is a different thing. Then you need the excision. But what is vaginismus? It is basically fear in the patient mind about the penetration or inserting anything. There is no lack of space. It is, everything is because of fear. Patient is not allowing to insert to have intercourse. So we are basically have to relieve that fear of from the patient mind.
Correct.
Yeah.
What I wanted to say, the vaginismus is not only locally, it is from even mind also. Many patients have fear about that the penetration is going to cause the pain. So very truly said by the previous speakers, we have to show them anatomy. One thing which I tell my patient is, if your mouth is closed and if you want to eat something with spoon, if you're closing your mouth, how you're going to eat? You have to let your mouth open and then only spoon is going to go in. And one more thing I tell, the God has made your vagina in such a way that baby can come in. When such a big head is able to pass through vagina, and so many people deliver vaginally, so it's no problem of getting 1 finger, 2 finger or 3 fingers going in the vagina. So we have to make them mentally, we have to relax them how it is, and really talking to them, and counseling is very important for vaginismus. If there is no pathological cause, there is no infection, and gradually only you can do the dilatation. One of my teacher who told me there were never used to be dilators in the initial days, na? So in MP, we used to get those bangan, lamba wala bangan, brinjals, long brinjals. So she told me that she used to tell her patient to apply some oil on the brinjal and use the brinjal for dilatation, just because we were talking about dilators. And one more incident I want to just quote here. Just few months back at night, 11 p.m., I got one call. One girl came to me, Madam ko milna hai, Madam ko milna hai. And when I went down and saw, तो मैडम आपको बहुत important बताना है, अभी क्या हुआ? So she said there is foreign body down there. चलो भाई foreign body है तो ठीक है, we'll remove it. No, madam, it's foreign body down there. Pardon?
Candle
Go
probably.
ahead, go ahead.
Foreign body was not in vagina, it was in anal canal. Now, this was a big tough question for me कि anal canal में foreign body कैसे जाता है and how am I going to remove it? Then when I tried to do first I did a PV. I could feel something so big, like our index finger, na, इतना बड़ा thing could be felt hard, something is there. If you do a PR, it used to go up. It was very difficult. It was very difficult for do. I have to get use of, I called a surgeon with a proctoscope and he removed it. So we are not trained for these type of things which are going to come to us in future. Which, I mean,
What was it, madam? But
Ma'am, what was the foreign body?
What was the foreign body?
toy, the sexual toy which he introduced in our anal canal.
Anatomy is very
Candles also
important.
they introduce. Candles also they introduce.
So basically, dilate
Yes,
here,
sir.
basically
Yes, sir.
dilator is a wrong terminology here. We are not dilating anything.
See,
We are
she was
just
not dilating. She was using a toy.
no. I'm telling about this desensitizing with the dilator.
I just talked about this
Yes,
thing.
yes.
I was not aware that the toys are there. I came to know that time. They introduced in renal canal. I was absolutely not aware. So I thought I have to read a lot what new things are in for the section. So only we can provide them. And I was really clueless. So
Basically, vaginismus is a reflex or involuntary thing. There is a fear of pain that will lead to the contraction of the musculature, and that will not allow the entry of finger or penis. So we have to break that cycle, and by using desensitization or by the different psychotherapy method or counseling method, basically we are removing the fear from the patient mind.
Yeah, mindful relaxation also helps, especially
Yes.
when they are undergoing the act of penetration. The woman may land up with anxiety.
Yes.
So that fear factor, she can undergo mindful sessions also during the act. She can learn to relax. So
Right.
those also helps.
Yeah. So who is going to tell us about the Botox therapy? Because
Can I,
nowadays,
sir?
yes, please.
Botox comes in a vial. If you open it, looks empty, as if nothing is there. But you have to reconstitute it with 0.9 ml NS, and each 0.5 will give you 20 units. So you inject at 2 to 3 points. Actually, 2 points, 50 units at the pubococcygeus muscles, and other sites are usually to be avoided because the side effect of Botox is it causes incontinence. So if you don't want incontinence, you should be injecting it very properly at the 5 o'clock and 7 o'clock positions. But I prefer that Botox should be the last, just because nowadays cosmetic gynec is coming into fore, then every vaginismus should not be treated with Botox.
Yes.
Like every beauty parlor you go, hair loss, they give you Botox. So Botox is a good as well as a bad.
Yeah.
Good,
So
yes, it has effect, but bad is if it anal incontinence, then that incontinence lasts for about 6 months. So very careful while using Botox, and maximum dose should be 180 units.
yeah. So basically, only in 10% or less than 10% cases of vaginismus, you will need Botox therapy. Rest of the cases you can easily manage by the counseling and by the desensitization technique. Yes, Madan, you can carry your message for Madan. Where he went? Madan, are you there?
Yes.
Yes.
Just to summarize this vaginismus, it is a common sexual dysfunction noticed in gynec, mainly the gynec practice. Prevalence is increasing day by day, and it significantly affects the woman's emotional health, and the quality of life is hampered. In these cases, the proper evaluation, proper history, diagnosing the underlying cause, keeping the differential diagnosis, assessing the severity of vaginismus, and the best possible treatment should be given. And always a multimodal approach is needed for the management. Yes, next. Okay. GSM is another thing, genitourinary syndrome of menopause. As we all know, the sexuality in elderly, it is frequently misunderstood and many times it is neglected and ignored and disapproved by other people. Then that is why we have to understand this thing now. Women's sexuality has emerged as a central concern after the years of neglect in the medical world. And healthy women spend 1/3 of their lives in postmenopausal women. Next. Then who will throw light on this genitourinary syndrome of menopause?
Sir,
Yes, in
genitourinary
short,
syndrome
yes.
earlier was the vulvovaginal atrophy, atrophic vaginitis. Now all this has been clubbed under one in the 2014 definition. That is progressive vulvovaginal sexual and lower urinary tract condition, which is characterized by a host of symptoms, which is secondary to the clinical state of hypoestrogenism after the onset of menopause. Like estrogen is the heroine of our body. And after we reach menopause, the movie में मजा नहीं आता जब heroine नहीं है. It is like that in a female's body because no estrogen, all the conditions, be it stress urinary incontinence, atrophic vaginitis, dyspareunia, everything comes because of lack of estrogen.
Yes, it is an umbrella term covering many things. Then how to go about the management of this part? What is the role of medications? Which medications are available? What is the role of moisturizers and lubricants? Deshmukh ma'am, can you highlight these things? What is the role of moisturizers
Yeah,
and
commonly using moisturizer and lubricants in menopausal age group. So we are all aware about it.
Yes, these are the
Moisturizer
general.
the ability to ejaculate water, which is then released and locally result in increased hydration, thus mimicking physiological vaginal secretions. Nowadays, we are getting many pelvic gels. Many companies are coming. There are lubricant gels, and we see these gels not only give lubrication, but they can have less dyspnea, less pain due to these menopausal patients who have atrophy of the vagina and less of estrogen. So they can also enjoy sex if they apply these lubricants. While moisturizers are intended for chronic maintenance to replace vaginal secretions, lubricants are specially designed to reduce the, you can say, reduce the friction during coitus, whatever is happening. So, and reducing dyspareunia also before that, because many of times postmenopausal patients generally they come with dyspareunia maximum of times, and they ask for estrogen therapy because they read from Google and they ask for, and if the patient is having a uterus inside, we can't give them estrogen therapy without progesterone. So in that case, we have to see to it, better give them lubricants if all the metabolic disorders are excluded. If they have metabolic disorders, then lubricants are a must. And if no metabolic disorder, then we can replace them with estrogen and some amount of progesterone for small time, but not continuous as they are already menopausal. So other things are glycerin, silicone. I don't find this to be that much helpful, but we generally give lubricants to these patients. And one more thing I would like to add to orgasm, as you had earlier told, we give in my IVF practice, I give testosterone gel to patients before inducing them for IVF cycles if they have low AMH, because they have low estrogen also. These patients we give DHA is not that much practice, but testosterone gel is given before induction of ovulation cycles so that they get more follicles, more estrogen is developed in them. And they also have many a time they conceive naturally also after induction of ovulation. That I wanted to add because this is an interruption in the earlier schedule.
Very good inputs from you. So
Yes.
lubricants and moisturizer should be always as a first line of treatment when there is a GSM patient come to you. We all using local estrogen therapy. Can anybody tell how we should use when there is a GSM problem? Local estrogen therapy.
May I?
Yes, please.
Most commonly we use in the form of the vaginal creams or gels, in the form of estriol creams, and vaginal tablets also can be used. Vaginal ring, I am unaware if it is available in India. So vaginal creams and gels are often used and they are easy to use and also act as a lubricant. Other thing is that those can be used not only in postmenopausal, even in the post-chemotherapy patients who have undergone breast cancer surgeries. All these patients, it is very safe option. And now I think in the West, it is promoted left, right, and center. because it not only helps in the sexual dysfunction, also the urological symptoms in the postmenopausal women. So this typical administration, which is we give it daily for approximately here it is 2 weeks, but we give it for 4 weeks, and then we do it as a twice a week for the subsequent days. So that is the vaginal estrogen application. Tablet forms we can give in the form of estradiol valerate or hemihydrate. But we don't use it for, we prefer gel constitution or a cream constitution only for these patients.
So, Dr. Kavita, how long you can continue local estrogen therapy for these symptoms? How long you can safely
Till
continue?
the symptoms resolve, I think we can very well continue it. Maximum 12 weeks we can continue.
But after 12 weeks, suppose you stop, then symptoms will again come back.
The latest study which I have read was that can be continued as long as possible up to 9 years, I guess.
Yeah.
I agree with the last point, ma'am. Vaginal estrogen cream can be continued for as long as the patient is able to use it. The initial dose is twice a day for 2 weeks. That is the loading dose. And twice a week at bedtime is the maintenance dose, and it can be used for as long as it's possible. And the local estrogen creams are absolutely safe. And usually, even with presence of uterus, with the use of local estrogen cream, progesterone support is not necessary.
Not necessary, exactly.
Yeah, so it's very safe. Even you can continue for longer duration because so many of our gynec friends are afraid of using for longer period of time. But it's proven that it will not harm anything if you
Sir,
continue.
and especially as a urogynecologist, we use it for very long term because it has known to improve the local immunity as well as vascularity and muscle strength. So, especially in patients of recurrent UTI and overactive bladders, we give it as an adjunct therapy, the local estrogen therapy. That definitely helps in the management of LUTS.
Maximum how many days? How many days? How many
Ma'am,
weeks?
as long as patient can use. The loading dose is twice a day for 2 weeks, and then twice a week at bedtime, maybe Tuesday, Thursday, that way. And it comes with an applicator with a mark. So up to the mark, the cream is filled, and the cream is the easiest to use for the patient because they not be able to insert the tablet very comfortably. The tablet may slip out, but the cream gets absorbed locally very nicely. So patients are very comfortable in using the creams.
Yeah, so perfect carry on message by you.
Dr. Ashi, which estrogen you prefer? Estriol or
Sir,
estradiol?
Estriol. Estriol has been proven.
Yeah.
Okay.
Yeah, so Dr. Prakti was telling about role of Tibolon. Anybody wants to add anything about Tibolon?
It is discussed already, I think.
Yeah.
Next.
If anybody wants to add anything about Tibolon?
Role of-
Selective estrogen receptor modulator. Is there any role of SERM? Because ospemifene is usually not available in India. It is available internationally. So we have a very limited option about the SERM, which is useful in the GSM or sexual dysfunction. Yes, Madan, you can continue
Yes.
the cosmetic part.
Yes. Nowadays, so many energy-based devices are available, which are used in the management of this thing, sexual dysfunctions or genitourinary syndrome. Radio frequency lasers are available. HIFU, some HIFM is available. Some minimally invasive procedures like PRP, fillers, Botox, many things are available. And in the surgical part, some label surgeries or nuclear hood surgeries, perineoplasty that are being done for this purpose. Anyone can highlight about, in short, what is the role of PRP?
In vaginal
PRP,
Yes, ma'am.
PRP is the new kid on the block, sir. It is the autologous and magic potion. I would say it is a magic potion. You have to see it to believe it. I believe ki more than estrogen creams or anything, PRP and these laser-based devices are a boon for patient of GSM, especially for stress urinary incontinence, for a dry vagina. PRP is enriched with several growth factors, and it causes get released in response to the cellular damage, and it stimulates the process of fibroblast collagen synthesis. The vaginal epithelium actually becomes like a new vagina, and the patient satisfaction is tremendous. We have had case studies where what happens in GSM is that you stop treating the woman as a sexual being. Suddenly, after she becomes a mother-in-law or a grandmother, you don't consider their sexual history. And dyspareunia is the major problem for them. And in such patients, even a dry vagina causing constant itching, repeated vaginitis, PRP has an absolute beneficial role.
And
Ma'am,
Dr.
Ma'am,
Purnima, how
what is the
long?
duration of?
Yeah.
Same question, sir.
Yes.
Purnima ma'am, do you prefer PRP in the same setting of laser?
Yes, sir. We have
Okay,
been doing PRP in the same setting of laser, because calling the patient again and again, come after 15 days. There are two schools of thoughts for this. Some say
Yeah.
do it together, some say do
After
it
15
after
days.
15 days. But we have been doing together for almost 2 to 3 years now. We have not found any complications or any side effects of not doing it in the same setting. It is
Is
your
PRP
comfort
What
and
is
the
the
patient
duration?
comforts.
Is PRP
What
useful
is
in
the
the mild
duration of
SUI?
effect of?
SUI?
Sir?
Is PRP useful in mild SUI?
Yes, sir. PRP,
Okay.
laser, and the HIFM chair.
And
You
do
have to
you
come
need repeat session of PRP?
repeated sessions, sir. Repeated sessions. Cosmetic gynecology, it is not a single sitting.
I'm
You
asking
have
about
to have
PRP.
repeated sittings, at least 4 to 5 sittings, sir. Depending upon the patient's condition, but minimum 4 to 5 sessions.
It is okay about laser, but what about PRP?
PRP also, sir. You have to have repeat session. You get good results after one sitting, but the actual effect starts after almost 3 months.
Okay.
So you have
Ma'am,
to
so
have
what
repeat
is the
sessions.
duration of effect? How long does that effect last?
PRP effects last for 1 year, one
Yeah.
1.5 year.
Approximately 1
So
year
after
minimum.
that, do you need to repeat those
Yes,
sessions? Because
yes.
in my opinion, like patient can continue to use the estrogen creams, but for PRP, after 1 year, she again needs to
Yes.
get those
See,
sessions.
cosmetic is like all skin procedures where you have to have maintenance treatments.
Yeah.
Cosmetic
No need to
gynecology
go
is like
no need to go to urogynecologist.
everything has to be a combination.
Yes.
You
of
start
course.
with this, your patient gets result, then keep continuing. Only estrogen cream sometimes may not help.
Dr.
Just,
Purnima, you can continue about the energy-based device.
Sir, we use mostly laser diodes, sir. My work experience is only on lasers.
It's okay. Talk
Laser
about laser in
diodes
short.
cause
In short.
neovascularization and neocollagenesis. So because this increases vascular and neural regeneration, and then it gives you good results, all these thermal energy based devices.
I think any EBD does the same thing.
Yeah.
Yeah. That depends
Depends
upon our
your
preference.
pocket, sir. What you
Yes,
want
yes.
to buy.
Yeah, bead is a big pocket.
So, Dr. Purnima, for common gynecologists, can you explain what are the different devices? How, what are the, from where they can start? Because they are in market, there are so many products are available related to energy-based.
I say for a first to start at a point, a laser-based device, a PRP machine, and a HIFM chair. These three will do. If not, at least to start with something, even PRP is sufficient.
Yes.
Nowadays, we are starting even with threads. We are working with threads for prolapse, vaginal mild cases of laxity. So that also, many high-end instruments like carbon YAG lasers, they are available. But I have no experience in that. But it is up to you, your way of interest, your pocket, everything, and your clientele, where you are practicing, how the patient is going to pay for you. Because you buy a high-end machine, then the cost also increases. You are buying a lower-end machine, you can pass on the benefits of the cost to your patient. I would say, because this my PRP works best for atrophic vaginitis, recurrent vaginitis, stress urinary incontinence, vaginal laxity. They are giving very good results.
Because nowadays so many Chinese machines are also available, so you don't know about their authenticity or what type of result they are giving.
Sir,
Yeah.
it is up to you. You have to, अभी market में बहुत आता है. You have to take a call. आपने study करना है. मशीन सोनोग्राफी मशीन्स भी बहुत अवेलेबल है. काम तो वो वैसे ही करते हैं. तो it is your individual choice, whichever works best.
Okay. Sir, next, yeah.
Hypo?
Next.
Yeah.
The effect is same almost. The conclusions. Sexual dysfunction in menopausal women is common and it is characterized by unique determinants and risk factors that go beyond the estrogen deficiency. Sexual issues in menopause are many times underdiagnosed and undertreated, and evaluation of these cases is very much important and crucial, and to make the awareness is very important, and treatment should be on individual basis depending upon the severity of symptoms and what is the effect on quality of life, and at the same time we have to think about the adverse effects and the personal preferences.
Yes,
I
sir.
think almost we have covered everything. Yes. Take home message. Sexual health is important for quality of life. Female sexual dysfunction is very common, as we know, and sexual functioning can be affected by illness, surgery, medication, and it is very important to assess the medical, psychosocial, and relationship factors. Don't forget to ask about desire, arousal, orgasm, pain, and at the same time the male sexual dysfunction. Kindly note these 5 things which are to be asked to our patients, and identify and treat the cause, educate the patient regarding the anatomy and physiology of these reproductive organs, and very important thing is to remove the myths and misconceptions. And last point is very important, always treat the couple, and as far as the history is concerned, we have to take individual history and later the couple history. That is very much important part as far as the sexual dysfunction treatment is concerned. And thank you so much, all the esteemed panelists, for giving the wonderful inputs. And we are enjoying this wonderful panel since 1.5 hours. Thank you, Neeraj sir, for conducting so well. And so many special thank to Deshmukh madam. Neeraj sir, Deshmukh madam is the president of Nanded OBGYN Society. She is the senior person. Yes.
Yes, madam.
We have on 11th and 12th of October, we have an infertility conference for 2 days. Jatin Shah sir, then Sachin Kulkarni, Chaitanya Shembikar, then Jila madam and Jay Mehta. All of them are together along with Sonal Pancha madam. We are conducting a conference for 2 days. I request you, I will be sending you personally the invitation to
Sure,
register for this conference. It's just 5,000 rupees for 2 days.
Sure,
So I'll
sure.
be sending on individual phones. If you send me a hi, or if this is on your group, I'll send it to, this will go to each and every one of you.
Sure, madam.
And I request everyone.
Madam, I expect registration from
Yeah.
Beed.
Yes,
Nandi
madam.
madam, I expect registration.
Okay.
Yes, yes, madam, definitely.
So all the panelists, it was a fantastic discussion with every one of you. Thank you for joining.
And I will say,
Thank you, sir. Thank you.
everyone to support Dr. Neeraj Yadav. He's on a big move.
Yes, Neeraj
So
Yadav.
Yes.
support him, and it should
Thank
be.
you.
So we keep on spreading sexual education and sexuality knowledge, which is need of an hour.
Thank you.
I thank Neeraj sir and Madan Kamble sir for giving us this opportunity be on this show. And best of luck to sir for
Thank you,
his
All the best.
election.
Yeah, all the best on behalf of
नांदेड़ और नागपुर कर जरा संभाल लो.
Nanded
नांदेड़ और नागपुर big society.
Yes, sure. So hai.
So send your cell number and address.
Nanded, Nagpur and Neeraj, they go na. Nanded,
Yeah,
Neeraj. So it is there to koi baat hi nahi. So at the same time, I also take an opportunity. We are hosting a menopause conference, zonal menopause conference in Nagpur on 9th and 10th of August. So I really want all Nandedkar, Nasikkars, and all from Pune and everyone to join us, whether you are also there. Dr. Neeraj, if you can make it, it's on 9th and 10th August. And we are
Very nice.
conference in Tadobai, that is in the core jungle in a resort with the safari. Deshmukh
So,
madam,
yeah.
Definitely, definitely. You can send me the brochure.
Please send
I'll
करके
share it with my society. Definitely.
I also take
Madam,
opportunity
please
to
send us
yeah
questions.
I also take opportunity to welcome you all to Nasik for the VP conference and NOGS annual conference that is on the 6th and 7th of December. So it's winter and you have beautiful Nasik and the organizing team inviting you all. So I hope we all meet together. As we are meeting on Zoom, we physically meet and we have good time together.
Thank you, madam.
Thank you.
I hope
Yes,
we have a
doc-
group. Amesh sir, we have a group so that we can share the brochure of each other.
yes, sir, you can share on the group this webinar.
we'll share on the WhatsApp group so that everyone come to know, na? Correct.
Yeah.
Yes,
Yes.
Dr.
I would
Vaidhi,
like
can you
to take
please
the
have a vote of
opportunity,
thanks?
sir. Sir, can I just
Yes, sir.
say a
I
small
will do that.
thanks?
Yes, yes.
I would like to thank Neeraj sir and Madan sir for giving me this opportunity. I am a very, very new member, very new at Nagpur, and trying to promote urogynecology. And it was a good experience for me to interact with all the seniors. And thank you very much for all of your inputs. And I got to learn a lot. It was a nice interactive session. And thank you to all of you.
Thank you, Dr. Ashish.
Thank you.
Neeraj sir, please
Yes.
send your address as well as a cell number so that I
Yes,
can
sir.
share with the patients.
I have already been once in Nanded. Sridhar is a very good friend of mine.
Acha. Oh, Sridhar Ralukar. Okay, okay. He had sent it to us. Okay.
I will send you.
Thank you. Okay, sir. Thank you.
Yes,
Thank you, Kamesh
please.
sir, Neeraj sir. And all the
So
panelists.
already everyone has said thanks to each other, but let me do it formally again.
We should
So
salute
today's
you, ma'am.
webinar was
We should
expertly.
salute you and every person.
Thank you, ma'am. Thank you. Thank you so
Thank
much.
you.
So although it was a informal thanks, so I just want to thank you all formally in the form of vote of thanks. It wasn't just a meeting, but it was academic triumph, and the topic which was discussed was a very unusual topic. I sincerely extend my thanks to our chief guest, Dr. Alpesh Gandhi sir. I think he has left the meeting, but my sincere thanks to him. And we are also incredibly honored to welcome Dr. Bharti Abhyankar Madam, Dr. Rajendra Singh Pardesi Sir, and Dr. Sampath Kumari Madam as distinguished guest of honor. Their presence was significantly elevated. Their presence significantly elevated the prestige and academic rigor of the occasion. And our special thanks to Dr. Neeraj Jadhav Sir. He's the chief faculty for the today's session, and his unparalleled expertise in this subject and his role as a moderator for the panel discussion was nothing short of excellence. His unwavering dedication to the committee and his objectives is deeply appreciated by all of us. And I have seen him personally been so much dedicated for all the sessions, for all the webinars of sexual committee. So we extend a huge round of applause to all the brilliant chairpersons also who graced us with their presence and guided our with the sessions. Especially Dr. Kavita, Dr. Poonam Belokar, Dr. Purnima Yande, Dr. Ashri Pargania, Dr. Snehanjali, Dr. Surya Kumar, Dr. Pragati Kharatkar, and Dr. Aishwarya. And their contributions were vital to the smooth flow and intellectual depth of the webinar. My special thanks to Dr. Madan Kamble sir, whose efforts has been tireless, and his relentless commitment and meticulous organization ensured every detail was perfectly handled. And we also immensely grateful to Corona Remedies for their generous support in providing the platform. And finally, last but not the least, our audience. So with this formal vote of thanks, I think we can end with this session. Again, I just want to remind you all that Dr. Neeraj Jadhav sir, he is going to contest for Vice President VP West Zone. And I request you all and from your committee, from your societies to support him